Okay, hey everybody. Here is our first lesson on Unit 3, which is ischemia and infarctions. Ischemia and infarctions have to do with heart attacks. So there'll be some changes in the EKG. You guys have gotten really good at looking at like the heart rate, NSR, tachybrady, the Ian-Thomas triangle and heart axis. So now we're going to take a look at what's a little bit different on EKGs. This is how we're going to diagnose or interpret what could be happening to them, and in the way of like heart attacks. So let's get started. It's going to be kind of funky for me. Okay, here we go. All right, so CAD. This is your note packet that says Thursday 321. Okay, that is your note packet for Thursday 321. So CAD, what does CAD stand for? And maybe you've heard this before. It stands for coronary artery disease. That is a narrowing of the arteries due to some plaque that's built up and or hardening of the artery tissue itself. So if we take a look at some pictures down here, this right here is an artery that they've kind of plucked away from the heart here, the coronary artery. And this is some plaque buildup. This type of plaque is usually caused by high cholesterol diets, obesity, diabetes, things like that. Actually, let me put that up because that is your risk factors. So, risk factors of CAD, people that are common or have a higher chance of getting CAD is includes family history. So, if you have a strong family history of it, it's kind of hard to get away from it sometimes. Hypertension, so chronic high blood pressure that you might have had throughout your life. If you smoke, if you have hyperlipidemia, which is just a fancy word for high cholesterol, obesity, diabetes, alcohol and drug abuse, obviously, any of those can cause some narrowing of the blood vessels due to some plaque buildup or even just hardening of the arteries. The arteries aren't like loosey goosey anymore, they get kind of hardened. So if you think of this like a pipe, obviously like a pipe like drain in your sink or whatever in your bathroom, and once it's nice and clear, water can go through. So the blood can go through very easily and quickly. But as soon as we have a clog in there, one of these little things right here, then it's not going to be so easy for the blood to go through. So the question is, why is this bad for the heart? Obviously, if we're not getting blood flow through the coronary arteries that surround the heart, these right here, if we're not getting good blood flow down here, specifically this one right here, this blood vessel, the coronary artery right here, feeds the left ventricle with oxygen. So if that left ventricle is not getting oxygen, it's not going to pump. So really bad for the heart as far as like trying to get oxygen to the heart muscle and make it work properly. That's the reason it's so bad. Okay, so CAD is coronary artery disease. Most of the time I hear about this running in families. It does run in my family. I don't have it at this point. My dad had it. My grandmother had it. I try and avoid all these other things, all of these other risk factors so that I don't end up with the family history taking over. All right, so what does that lead to? So if we have some narrowing of the blood vessels, okay, then we have something called ischemia. Okay, so ischemia is just really a word that means like an inadequate blood supply to the heart. So if we don't have enough blood supply, and there's a nice picture here, if there's a little bit of a blockage or a slowdown of process of the blood flowing down here towards towards that left ventricle again, we have reduced blood flow, right? So this is a problem. Again, it's typically caused by CAD. So CAD leads to ischemia. Okay, so ischemia is a fancy word for narrowing of the blood vessels or inadequate blood supply. So that the it's close to being blocked. Might not be 100% blocked, but it's close to being blocked. There's some sort of blockage in that blood vessel to the heart. They get symptoms that's similar, very similar. Sounds a lot like a heart attack. People come in think they're having a heart attack when it's just ischemia, which is actually good because heart attack's worse than ischemia. So they have the symptoms of shortness of breath. Sometimes that's called dyspnea, dyspnea, dyspnea. I think you have that med term for sure. Extreme fatigue, they have dizziness, lightheadedness, chest pain, heart palpitations, leg edema. Edema is just like swelling of the legs. They retain fluid, so the heart isn't able to pump as well as it should be able to, so it doesn't circulate well at the legs and feet. So that's where we get leg edema from. It does change the EKG. So we have this patient that comes in, say the emergency department, and they have all these symptoms, and I want to go like, is it a heart attack or is it just ischemia? So we're going to hook them up to an EKG, and then I'm going to notice that on the EKG, if there's what's called ST depression or T wave inversion, and I'll think about it for a second what that means and I'll explain it. But ST depression or T wave inversion, those are the two things right away that we can determine if they have ischemia, narrowing of the blood vessels in that area of the heart. Okay. So ST depression is that ST segment. Remember, we have the regular PQRST, right? Go that way, PQRST. And that ST segment, and there's a J point, we learned this a couple weeks ago, where the QRS comes back and meets the isoelectric line all the way to the T wave. So between the S and the T wave, that's the ST segment. And right there, that little point right there is called the J point. So we're looking at the J point and the ST segment. Now, if it is depressed, that means that that ST segment is going to be lower than the isoelectric line. I'm going to say it again. Think about what I'm saying. So that ST segment, that little piece from the S over to the T, is going to be lower than the isoelectric line. Okay. I'm going to show you a picture in a moment. T wave inversion is exactly what it sounds like. That T wave that's at the end, that's supposed to be a positive deflection, will now be a negative deflection. It'll be upside down. So the isoelectric line is here. Instead of the T wave doing this, T wave is going to do this. Okay. So, and the deeper the T wave inversion, the more blocked it is. We're going to learn that too. Okay. So ST depression and T wave inversion. I asked you on your paper to draw them. So I drew them for you. I'm going to show them in the screen here really quickly. This one right here is ST depression, and this one is T wave inversion. See, the T wave is upside down. And here, the ST segment right here is lower than the isoelectric line down here. You know, you don't have to be a great drawer to do that. It's okay. If you want to skip that part, it's okay. We're going to skip to the next page. And there's some good pictures for you coming up anyway. Okay, so don't fret about it. Obviously, during these lessons, if you need to stop and pause for a moment while you finish your notes or go back and listen to me say something again, you're welcome to do that, okay? And obviously, always send me a message if you can't understand something. Okay, so angina or angina, you can say it either way. Angina is a fancy word for chest pain. Okay, it just means chest pain, pressure, or squeezing in the chest area. If you have chronic angina or chronic angina, you have usually you have ischemia in there, and it's caused by reduced blood flow from the heart to the heart muscle, which is a definition of ischemia, right? So angina is the fancy word for the pain that you feel. Okay, that's all that is. Yeah, so it's a sign that the parts of the heart aren't getting enough oxygen, obviously, and it's typically the first sign, the symptom of CAD and ischemia. So that's how we kind of know firsthand if there's something going on inside the chest to the heart, is that we'll have these symptoms. It's like when you're sick with the flu, you start to have symptoms, right? This is a symptom of ischemia or a heart attack. Okay. So this presents in men almost every single time, left-sided on the, you can see it here, left side pain with the jaw pain down the shoulder in the left arm. Sometimes it's numbness, sometimes it's pain. Women present very differently sometimes. It's sometimes chest pain. A lot of times it's back pain. Still in the center, but in the back. A lot of times it is just the jaw. Sometimes it's the neck. Sometimes it's the shoulders. Sometimes it's abdominal, but they think it's abdominal. So women, I do a lot more EKGs on in the ED just because any of those things could mean a heart attack. And of course, if they're higher up in age, if they're 50 or older, have any of those risk factors that we talked about before, they're higher risk of having this sort of thing, angina or ischemia or CAD. Okay. All right, let's keep going. All right, so write this on your paper. Number 4, signs of ischemia on an EKG, very, very specific ST depression and or T wave inversion. So you might see depression in some of the leads, and you might have T wave inversion in others. They mean the same thing. Okay, it just so you know, they mean the same thing, that we're looking at narrowing in those blood vessels. All right, and the blood is having a hard time getting to some of the parts of the heart. Not the inside of the heart, around the heart, the arteries that surround the heart muscle itself is having a hard time getting oxygen. All right, so this is a really good slide. So this shows 3 different types of ST depression, and I can show you very clearly and easily what this is here. So here is our isoelectric line right there. and we have our P, our Q, our S. Here's our ST right here. This segment right here, notice how it's way below the isoelectric line. That is what ST depression looks like. And this is named horizontal because the ST segment stays flat and parallel to the isoelectric line, but it's well below it. Okay, so this is considered horizontal ST depression. Okay, this one over here, just a different morphology. It means the same thing. They all mean ischemia. There's just a different morphology of them. Okay, this one is a downsloping, so it kind of looks like a ski slope. We have our P, Q, R, S, and then our ST segment continues to go down, 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 and then it shoots back up to the T wave. Okay, so it's still well below the isoelectric line. It's just going down, down, down sloping before it shoots back up. And then our last kind is called upsloping. So this is also ST depression. Because that ST segment is way down here, even though it is eventually makes it up there, it still starts way down here and it takes its time getting up there. Normally, if this was a regular EKG, this would be right next to each other, right? This QRS is usually pretty thin and it would be right next to it, but it's taking its time getting up there. So this is an upsloping version of ischemia, of ST depression. I see this upsloping type on stress tests quite often if they're walking on a treadmill. Now, most of us have an ischemic response when we exercise. Sometimes it's normal. So if it's a really not as wide, this is kind of a normal looking ischemia. We'll see this on a stress test. Now we're going to push somebody on a stress test as hard as they can go. As we can get their heart rate as high as we can, and they're going to really push hard. So it is going to cause some sort of narrowing just because of pure anatomy. Okay, but these are the three different types. Definitely need to know these for any upcoming quizzes and for the certification exam. The horizontal, downsloping, and upsloping. Okay. All right, let's flip one over. So this is what I was talking about just a moment ago. There is a significant amount of upsloping and then a non-significant amount of upsloping. So if the upsloping is, like I talked about in the stress test, if it's not super duper wide, just a little bit wide, wider than normal, less than 1 millimeter, and like here, 0.08 seconds, which is just 4 of those, not one full box. So if it's not one full box, and I know this is, but it was just drawn for dramatic effect. Okay. Don't take it seriously, specifically. So if it's not very wide, like in that stress test, like I was talking about, it's considered a non significant one. Okay. This, when it's really takes a long time getting back up to the isoelectric line, this is going to be considered significant. So non significant and significant. That's the only difference between those two. Okay. And if you want to put down on your paper, if you want to circle like not very wide or and super wide, if you want to add those in there just to kind of remember yourself, teach yourself and remember, that's what you can do. All right, next one. Okay, so there is something called a medication called digoxin. This is given to heart patients that have congestive heart failure. Okay, a lot of people get to a certain age, and because of family history, weight, diabetes, other issues with their heart, they end up in what's called congestive heart failure, where the heart is just starting to fail. Okay, so they need some help, and digoxin is one of those medications that helps with the atrial pacemakers, the ventricular pacemakers, just keeps the heartbeat going. It's kind of having a hard time doing it on its own, so this is just kind of keep it going. Okay, so with this patients that take digoxin, it can change their EKG to look like and act like ischemia, ST depression. Okay, but it's called digitalis, and it looks a little bit different. It has a scooping shape to it. I'm going to show you what that looks like. Here it is. Okay, so this guy, he's from way back. But if you take a look here, so this would, notice the ST segment is kind of like a scoop. It's kind of like a mustache, or it's a rounded shape. None of our ST depression shapes, remember the horizontal upsloping and downsloping, none of them had this scooping to them. Okay, so digitalis is the effect from taking digoxin, the medication. So know the difference between the two. Digoxin is the medicine. The effect, the scooping effect that happens to the EKG is called digitalis. So let's take a look again right here. This is a really good example here. So you can see that normally have PQRS, right? T, and this ST segment is round. It's not horizontal, it's not downsloping, it's not upsloping. It's very rounded. That is the digitalis effect. You can see that here as well. Okay. If you look down here in EKG, we see a full EKG here. You can see some scooping here, some scooping here, scooping here, here, and here. So it's not in all of them, just happens to be in some of them, wherever the heart has needed the most help, okay, in those regions of the heart. So that's what digitalis effect is. If you want to, on your paper, I believe you have these pictures. If you want to circle the scooping effect on there, you certainly can. I have the smaller ones I see. I have your paper here with me. Okay, so let's talk about infarctions. Enough about ischemia. Let's talk about infarctions. So, an infarct means that we have death of tissue, okay, because it's not getting any oxygen. So, death of any type of tissue is called an infarct. I know that's a funny word. So, if we have a myocardial infarction, myo is heart muscle, right? Myocardial is heart muscle. So, if we have death of heart tissue, we have an MI, which is considered a heart attack. Okay. So a heart attack happens when a portion of the heart does not receive oxygen, and that part of the heart muscle actually dies, called necrosis. Okay. It actually dies. So it literally means a myocardial infarction, literally means death of heart tissue. Okay. You can see the pictures down here are showing a blocked artery. Now, with ischemia, there was some sort of blockage there to begin with, but it wasn't big enough to completely stop the blood flow. In an infarction, it's usually 99 to 100% blocked in this area, and that means everything below it, all this area down here is not receiving oxygen. Okay? So this part of the heart muscle will die. And this, you're guessing right, this does change the EKG as well. Okay, it's not going to be an ST depression now. We're going to see ST, what's called ST elevation. So a little blockage, ischemia, causes ST depression or T wave inversion. A big blockage and an infarct, okay, it's causing a heart attack, is going to cause what's called ST elevation. We're going to look at that in a moment here. There's different types of MIs. We're going to go through those too. So let's talk about the different types of MIs. So an AMI is just an acute MI. Acute just means it's happening now or just happened. Okay, it's happened suddenly. Acute angles in math, that's how I remember it. Acute angles in math are small, right? They're small angles, less than 90 degrees. So it's small. So acute means a small amount of time. Okay, so acute MI means it's just happening now. A STEMI, that literally stands for ST elevation myocardial infarction. ST elevation myocardial infarction. So we're taking the ST segment, and you're going to see a definite change on the EKG where the ST segment is well above the isoelectric line. It looks really funky. I'm going to show you several examples, okay? So there's also called an NSTEMI, a non-ST segment elevation myocardial infarction. That means they have all the signs and symptoms of a heart attack. They come in with the chest pain, the sweatiness, the clamminess, the gray in color, and all kinds of weird colors, right? They come in, and I hook them to the EKG, and their EKG really doesn't look different. It doesn't look like a heart attack on the EKG. But because they're having such strong symptoms, we're going to check them out anyway. So we can check them out by pulling some blood samples from them. That's another thing. And we can do a chest x-ray. So we're going to first pull a blood sample, okay? And we're going to check something called the troponins. So a troponin is an enzyme that your heart emits when it's had some sort of damage. Okay. So us normal people walking around today, our troponin levels are near zero. But if we've had some sort of damage to our heart, like a heart attack, or even a blow to the chest, so like say someone was playing baseball and they got hit in the chest with a baseball going 90 miles an hour, or that football player last year, Damar Hamlin, I think his name was, where he got hit in the chest and he went into cardiac arrest. Right? I'd love to see his EKG, by the way. So any blow to the chest is going to cause your heart basically to cry out. It's going to put out this signal through troponins. Okay, so it's a troponin level that we check through the blood to see if the heart has had any damage. Okay. So down here at the bottom, it's kind of cool here. So down at the bottom, you can see PQRST. This is normal, right? Now look at the STEMI, the ST segment. This ST segment is well above the isoelectric line. See this ST segment? See how high up it is? Well above the isoelectric line. Okay. So we call this a fireman's hat, or the EMTs call it a fireman's hat. If you've had Miss McVeigh's class, they call this a fireman's hat. Okay. And it means that if you take a look here, this is kind of like the front of it, and this is the back of the fireman's hat was sitting sideways. Yeah. So a STEMI is a heart attack. When we take a look at this EKG over here, I when I start looking at EKGs, and I want you guys to start practicing this too. I want you to look at the different regions. You just did the regions. We did the regions together on a video again, also last week or 2 weeks ago. Okay. So remember the regions that go together. So we had lead 1 and AVL. We had 2, 3 and AVF. That was inferior. 1, 2, 3, and 4 are all anterior. And then 5 and 6 are apical. Okay. I'll review it again. 1 and AVL was lateral. They go together. 2, 3 and AVF were inferior. They go together. 1, 2, 3, and 4 are anterior. We did have right septal and left septal, but they're all anterior, so they doesn't matter. And then 5 and 6 are apical. So when I see a change in one lead, I want to make sure that it matches with another one in the same region. So if I see a change in lead 1, then I must also see a change in lateral for it to be what's called diagnostic. If it don't have a match in at least 2 of the same of the leads in the same region, then it's considered non-diagnostic. If I only have 1 lead with changes, it's non-diagnostic. Okay. So here in this region here, lateral, 1 in AVL, I do see a STEMI here. I see ST elevation. It's slight, but if you think about where the isoelectric line is here, right here, see it right here, and how this is elevated above it, and it looks a little bit like a smaller fireman's hat. Same with this one. This right here, that tells me they're having a heart attack. So they're having a myocardial infarction, a blockage in the blood vessel in the lateral region of the heart across the top. This is so important for surgeons and cardiologists when they're trying to diagnose and figure out where they can help this patient or how they can help this patient. When someone's having a heart attack, they need to know right away where to go in and find this blockage before the person dies on them. So the EKG is one of the most important pieces of information they get just before surgery. Okay. So it tells them, it's literally telling them where to go look when they're trying to find a heart blockage. They know where to look. Okay. Really cool thing. Then I look at 2, 3 and AVF. Okay. And I see a little bit of maybe ST depression here. Nothing really matches. So I'm going to say that's non-diagnostic down there. And I look at V1. V1 looks okay. V2, V3, and 4. These all look a little funky to me. This is definitely ST elevation. Here's the S wave way up here. And then it goes into this really tall T wave. Here's a fireman's hat, and here's a fireman's hat, and here's a fireman's hat. So 1, 2, 3, 4, I definitely have a blockage in the anterior region of the heart, as well as the apical, because 5 and 6 also have ST elevation. 5 and 6, that's the apical region, the one down in the apex, down in our armpit. Makes sense because 5 and 6 are placed in the armpit, right? Yeah, okay. So technically, there's 3 blockages that this cardiologist needs to look for when they go in there. They're looking in the lateral region across the top. They're also looking anteriorly and apically. There's potential of 3 different places this person has a blockage. So this EKG is vital, critical for them to help them to understand where they're going to look for any blockages. All right, let's keep going. So your coronary arteries, this is just an example of what they are and where they're located and what they're called. So, and it just gives you an example. This is your right coronary artery because this is the right side of the heart, and it wrap around a little bit. We have a circumflex and the left anterior descending. So left coronary artery, the circumflex wraps around, and the anterior descending comes down here. This is what feeds the left ventricle. Okay. So if there's a blockage right here, anything below that is not getting oxygen, just to let you know. Okay, just kind of an example. All right, this is another place showing you exactly what I just said. there's a blockage here, and now this area is not getting any oxygen. That's actually called the widowmaker, if you've ever heard that before. It's called the widowmaker because people that have an infarct in that area of the heart don't always make it. Like 70% of the people that have an infarct here usually, yeah, because the left ventricle can't squeeze. If the left ventricle can't squeeze and they can't get to it fast enough, then you don't have any blood circulating. So it's unfortunate. It's called the widowmaker because the person who has it makes their spouse a widow. Yeah, morbid, right? All right, let's switch on over. All right, so let's take a look at the ST and T waves. This is kind of like the evolution of a heart attack. Okay, this is kind of how it processes through. So as people are starting to get a little bit of a symptom, then they might feel a little short of breath, maybe a little chest pain, dizzy. At the beginning of the heart attack, we're going to have something called a peaked T wave. So the T wave becomes very tall, okay, very tall and almost tent like. It's got to be more than 2 boxes tall. Okay, this is called a hyperacute peaked T. You can write that on your worksheet. Then, as we go right into the heart attack, like right in middle of the heart attack, we have the ST elevation, and you can see that this is the isoelectric line, and here it is way above the ST segment is way elevated above the isoelectric line. This is classic ST elevation. This is a STEMI. Okay, this is considered an AMI because it's a hyperacute peak T wave. Then after we start to come down from the heart attack, so typically a heart attack can last 10 minutes, 20 minutes, whatever long, they have symptoms, and then they start to come out of it. The body starts to react to it and, get them through it. Most of the time, hopefully that's what happens. And when they start to come out of the heart attack, we start to see the ST elevation come down a little bit, and then we see a T wave inversion. So the T wave starts to flip over. We've got ST elevation, just not as high, and that T wave starts to flip. And then after the heart attack is all done, so if it happened a few hours ago or a few days ago, you're going to see an inverted T wave in the area of the heart where the heart attack happened, the region where the heart attack happened. Okay, so this is the evolution of a heart attack. Very beginnings of a heart attack, you'll see these tall peak Ts. Sometimes they're even bigger than the QRS. And you'll see ST elevation. As we're starting to come out of the heart attack, you'll have a little bit of elevation where the T wave flips over. And at the end of the heart attack, so a recent MI would be an inverted T wave. And again, the more deeply inverted it is, the more recent it was. Okay. Hope you've written those down. If you haven't, come back, pause, rewind, whatever you need to do to go through that again. Right, so here's another evolution. I have them starred, so I just want you to label the stars, that's all. There's one more piece to this that I did not show you before, so it's kind of just a review. A is supposed to be a regular EKG, okay? B, the star, so star yours on B. A, I would put regular or normal EKG. For B, put a star at the top of that really tall T. That is a peaked T, hyperacute peaked T. As we move over to C, where that star is, that is showing you the ST elevation. Excuse me. The ST elevation. You can see it kind of looks like that fireman's hat, right? Yeah. Excuse me. Now, when we move to the next one, it's going to be kind of weird here. We see that ST elevation is coming back down, and then we have our inverted T is the gray one. But you take a look at this red one. This is going to be a new one for you. Notice up here, the Q wave just kind of goes in very quickly, and usually the Q wave, it goes down, or it might stay level with the isoelectric, it might go down, but it stays really small and narrow, not deep and really narrow. But after you've had a heart attack, it leaves a permanent scar in that region of the heart, okay? It leaves this. It's called a pathological Q. That is spelled, you can see it on number 14 just below on your paper. It says pathological Q, okay? So the pathological Q happens after you've had a heart attack in whatever region you had a heart attack. So this Q wave, excuse me, my goodness, I'm so sorry. So this Q wave gets deeper and wider. It's subtle. You may or may not notice it on an EKG right away. Okay. I don't always notice it. It's not something I go looking for. Now, if they've told me they've had a heart attack before, I look for it, but it's not something I just normally look for. So as soon as we've had a heart attack up here, right? We had a heart attack. As soon as it's over, we have what's called now a pathological Q, and that's going to be a permanent scar in that region of the heart where they had the heart attack. So as we come out of the heart attack, you'll now have the pathological Q and the inverted T. And then after a few months, all the way several years from now, they will still have the pathological Q. It's like a little mark it's left on your heart that you can see on the EKG. Kind of something cool to learn. So number 14 just says the same with the pathological Q. If you want to label it, you can. But that's just pointing out that the pathological Q is going to be deeper and wider than a normal Q wave. And it's subtle. It's not something you're going to see. It's not going to be like super deep and super wide. Okay. It's not going to be like that. It's just a little bit deeper, a little bit wider than the other ones you would see on the EKG. Okay. So don't get too excited about the pathological Q or worry too much about it. That will probably not be on your certification exam, but something to be aware of. Okay. All right, so I like a good chart. So actually, this is just showing you what pathological Q would look like. If we had a pathological Q, it looks much deeper and wider. Okay, that's kind of what it looks like there. All right, I love a good chart. Charts summarize a lot of things. So these are the different things that you might see, you will or may not see on an EKG. So the first one is ST elevation. So if you see ST elevation on an EKG, it is definitely an acute MI. They're definitely having a heart attack right now. Okay. ST elevation does not mean a recent MI and it does not mean an old MI. You will only see it in an acute MI, one that's happening right now. Now, a peaked T, you may or may not see it in an acute MI. Sometimes we do, sometimes we don't. It is not indicative of a recent MI and it's not indicative of an old MI. So let me differentiate between an acute, recent, and old. I should probably do that. So acute means it's happening now. Recent means it happened in the last few hours to the last few days, maybe even a few weeks. Old means it's happened months ago, years ago. Okay. Now, when we see an inverted T wave on an EKG, it may or may not be there for an acute MI. Sometimes they show up there, sometimes they don't. It definitely will be there if you've had a recent MI. So we had one a couple of days ago, or we had one yesterday or last week. You'll see inverted T's in the region where you had the MI. It does not show up in an old MI. Okay. Fun fact about this, though, too. I see patients that come in to the hospital quite often, usually around the time we start mowing lawns and when we have to shovel snow. And that's when someone exerts themselves for the first time for a while and they have symptoms. They have like chest pain and stuff. They say, I had to sit down. I was mowing my lawn on Saturday. I had to sit down. I was having chest pain. I couldn't catch my breath. After like 10, 15 minutes, I felt a little better. So I finished the lawn, but I really haven't felt the same since Saturday. It's now Tuesday. So I thought I'd come and get myself checked out and I hook him up to the EKG and I see he has inverted T waves all over the place. That means he had a heart attack on Saturday while mowing the lawn. Luckily, it was a mild heart attack, and he was able to make it to the hospital to get checked out. Okay, and they'll do further testing from there. Then we have the pathological Q. So it's always there in an old MI. It may or may not be there in acute or recent. It just depends. It usually happens after the acute and recent has happened. Now, if they have multiple MIs, so if they had an acute MI 3 years ago, turned into a pathological Q, and now they're having another MI, they'll be in pathological Q on there because they had one 3 years ago already. This is a second one they're having, so it'll show up. But it doesn't always show up as an acute MI. Okay. All right. There's your chart. All right. So T wave inversion, we learned it can be two different things. It can mean ischemia, and it can mean a recent infarction, right? So how do we tell the difference, basically? So if we take an EKG, they had all the signs and symptoms a few days ago. So we have to find out some background about the patient. How old are they? If they had if they had signs and symptoms recently, if they had any chest pain, shortness of breath, sweating, passing out, anything like that, right? And if they have had those symptoms and we take an EKG and they're just laying on a bed and they have inverted T waves, they most have most likely had a recent MI within the last few days. Now, if it's not there, you do an EKG and they tell you all the symptoms and you do an EKG and their T waves are normal, and then we've put them into a stress test, like on a treadmill, and then the T waves flip upside down during the stress test. So it's normal at rest, but once they start to exercise, okay, and those T waves flip upside down, that is means they have ischemia. That doesn't mean they had a recent infarct, it just means they have ischemia. Okay, so hopefully that helps you a little bit understand the two different types of T wave inversion. You can rewind it if you need to go over it again. Okay, so an inferior infarct, this one right here is about 85% of the population. If they have a heart attack, it's usually in this area. Believe it or not, yes. So they happen in leads 2, 3, and AVF, right? Inferior, so that because those three happen with the inferior region of the heart, 2, 3, and AVF. So if I have to see a change like ST elevation in 2 of the 3 leads for it to be diagnostic. If I only see it in 1 lead, it is considered non-diagnostic. But then we're on number 17, where inferior infarctions happen in leads 2, 3, and AVF. And again, this is the right coronary artery is about 85% of the population. Now, when we talk about lateral region, lateral would be across the top, kind of like over here on the side here, since our apex point's here. This would include leads 1 and AVL. Okay, so 1 and AVL are lateral. So we would have to have a change in both of those, both 1 and AVL. Remember, we need 2 to match to make it diagnostic. So we'd have to have a change in both of those. This particular one is showing you a pathological cue in 1 and AVL. It's deeper and wider. But we could see ST elevation, we could see T wave inversion, we could see ST depression. If it was in both those leads, it would be diagnostic for the lateral region of the heart. Okay, so that's number 18. Number 19 is the anterior infarction. So anterior includes all 4 of those, V1, 2, 3, and 4. Again, it's showing you the pathological cue and what it looks like in anterior infarcts. But again, it could be ST elevation, it could be depression, it could be T wave inversion. As long as we have 2 of the 4 that match, we have a diagnostic test or diagnosis for that region of the heart anteriorly. And then our apical, of course, are 5 and 6. I guess I don't have that on here. No, I don't. Okay. So apical infarctions for number 20 are in leads V5 and V6, making sense because V5 and V6 are actually placed in our apex in our armpit, right? Yeah. And again, it's only 2 leads that represent the apical region, so they both have to have a change. All right, so how do we test for MIs and ischemia? How do we know for sure? We take an EKG and then is that it? No, we go further. Okay, so we have what's called a treadmill stress test. I do have the treadmill in my classroom, and this is one part of my job that I do quite a lot. Actually, a patient will walk on a treadmill. It is set for a specific program at certain paces and slopes, so angles, right? And we're monitoring their EKG changes, any symptoms they have, their blood pressure. And every 3 minutes goes a little higher, a little faster. It's a maximal effort test. They want people to go as long as they can. This is checking for ischemia. So if we're exercising and putting our heart under stress, then we're going to see how it reacts. So we're checking for ischemia for this one. We would not put someone on the treadmill that had a high troponin level. High troponins mean that they've had a recent heart attack, and we don't want to put their heart under stress if they've had a heart attack. Then we have a pharmacological stress test. So this means this person can't walk or not walk, with stress anyway. Walk strenuously up a hill at a fast pace. Okay, so they may not have a leg. They might have had a hip operation, a knee operation, a bad back. People in their 80s typically can't always walk up a hill like that. So we'll do a pharmacological stress test. So it's a medication that we inject into their IV that simulates what happens when you exercise. So it's going to increase their heart rate. It's going to open up the blood vessels. So when we exercise naturally, our blood pressure reacts and so does our heart rate. and so do our blood vessels. So in blood pressure, systolic blood pressure is that it should go up. Top number should go up in exercise because our heart is working harder. Okay, so the pressure should be higher. What's interesting is the diastolic one, the one on the bottom that measures the pressure in the blood vessels, should go down because naturally when we exercise, our blood vessels actually open up and vasodilate. They get bigger so that oxygen in the blood can run to our muscles faster. It's like one of those fight or flight syndrome things. Naturally opens up the blood vessels, gets blood to all of our muscles, our lungs, our heart faster. Okay. So the stress test that we give them pharmacologically does the same thing, increases their heart rate and vasodilates. They feel really funny because they're laying still and it feels like they're running on a treadmill or just ran up some stairs. They get hot, they get short of breath. It's weird. But we can check for the same sort of things under stress with a medication if they can't get on a treadmill. There is something called an echocardiogram that is just an ultrasound of the heart. It's kind of cool because you can watch the heart literally in real time squeezing those ventricles, the valves opening, closing. It looks really, really awesome. If you have a chance, Google search up echocardiogram pictures or videos. It's really cool. That's a video we're not going to watch. Okay, so heart blockage prevention. Just like anything else, they tell you you should. There are medications, yes, but I was going to go through this. They tell you that you should. Oops, I'm sorry. That you should exercise, eat right, and have rest and minimal stress. All of us do that every day, right? Right? No. I know I struggle with this every day. I'm just getting the amount of rest I'm supposed to have, right? Stress, talking about stress. You guys are seniors getting ready to apply to colleges and make those choices and all that stuff. Diets are hard to do because you're on the run, you're trying to eat fast food, right? Forget about exercise. But there are, you have youth on your side. So thankfully, you guys have youth, but it's good to get in those habits now early before you get to a point in your life where you'll have a problem. There are medications that help with heart blockages. If you have a known heart blockage or you have family history of it, it's they can take things called blood thinners. Aspirin is basically a blood thinner. It's just an over-the-counter blood thinner. There's something called a beta blocker that keeps your heart rate down. You have weird arrhythmias going on in your heart, it keeps that down. Vasodilators are obviously diuretics and cholesterol medication. All these can help keep your heart healthy. In addition to the stuff below, you should still be doing the stuff below: exercise, healthy diet, low fat and salt, rest, and minimal stress. Every day, my friends, that's what you should do. Keep your heart healthy. And I know I can't check off all those myself. So, but it's a goal of mine to start doing more of that. Okay. Okay, so heart block procedures. What if they do have a heart block? What if we noticed it on the EKG? The doc's like, let's go figure out how to get rid of this blockage. We got to take care of this blockage. So they'll do what's called a cardiac catheterization. They see that STEMI on the EKG. They know it happened in the lateral region of the heart because of this, because of the EKG. They're going to take a tube, a catheter. I know a lot of people think of catheters as going in the urethra. A catheter is just a tube. So you can put a catheter anywhere. So this is actually inserted near a vein, near your either near your groin area, like where your hip bends, or they can now do it in your wrist too. Just if you're a candidate. And they will insert the catheter in there. It snakes up to your heart. They then inject some dye into the heart arteries and watch it fill the heart arteries in real time on this x-ray machine. Okay. So if they're watching it fill in and then it doesn't fill in one part, the dye doesn't make it to one part of the heart, that's where the blockage is located. Really easy to find. Okay. And then once they get in there, they will probably place a stent. If that during the catheterization, they noticed that the blockage was there, they're going to try and stent it. So it's a little device. You can see this picture down below here that they slide in. It's all squished down really tiny at first, and they'll slide it in, and it looks kind of like those handcuffs you just stick your fingers in and can't get them out. It looks like that. Yeah. So they squish it down real small, and they'll place it into the blood vessel in here. They'll snake it through, and then they'll use a balloon called angioplasty and blow it up. And when it blows it up, it leaves it in here nice and open. It's pushed, notice how it pushed this blockage away. and it's left the blood vessel nice and wide open. That stent stays permanently in your body forever. If it's 70% blocked up to like 90 something percent blocked, they will place a stent. Now, if they cannot place a stent, it's not big enough in there. This blockage is too blocked. We can't fit a stent in there. They're going to do the next one. They're going to do CABG. This is called bypass surgery. CA stands for coronary artery bypass graft. Coronary artery bypass graft. Bypass surgery. So just like a highway, like when you go up to Philly, you can go through Wilmington, right? Take 95 through Wilmington, and that goes, and you usually run into traffic at certain times of day. But if you want to go around the traffic, you take a bypass highway. So what we're doing is basically making just a new highway for the blood to travel. So you can see there's single, double, triple, quadruple. So wherever the blockage is, say I have a blockage right here in my heart, right? My ring is my blockage. And the blood can't get through, but I need blood down here. So I'm going to take a vein out of the leg of the patient, their own vein, attach it up above the blockage, and then again below the blockage. So it makes a little highway around the blockage. So now that part of the heart can actually get oxygen. So my friend had 5 bypasses in one surgery. So he had 5 blockages that needed to be, I know, crazy, right? That needed a new pathway. So it's pretty good, pretty quick recovery, quicker than you think it would be. They're in the hospital for like a week. They're in ICU for like 2 or 3 days, and they move to step down, and then they go home, and then they do cardiac rehab for like 6, 8 weeks, and then they can kind of do whatever they want. It's really awesome. Okay, so that's what we need. I think that's it for today. All right, let's do some practice. So we're looking at we're looking for those things I talked about today. So we're looking for the ST segment to either be elevated or depressed. We're also looking for T waves to be inverted. Okay, so let's break it down by region. I want you to start getting used to doing this, breaking it down. But when you look at an EKG, look at regions. So 1 and AVL go together, 1 and AVL. I do not see a change in 1 and AVL. This looks like a regular old PQRST. 2, 3, and AVF go together. This is inferior. I do see some changes here. This is slightly elevated. This is definitely elevated with an inverted T, elevated with an inverted T. So these two definitely match, and this is pretty close to matching. So we've got elevation. ST elevation with T wave inversion is that end game of the MI. So this is a STEMI towards the end. Okay, so it's safe to say to the doctor or surgeon that they're having a infarct in the inferior region of the heart. And why is it inferior? Because it's in 2, 3, and AVF. That's the inferior region of the heart. Okay, so down below. Now look at V1, 2, 3, and 4. I don't really see much change going on. Nothing that matches anyway. 5 and 6 look slightly different. Maybe this T wave's a little wonky, but it's really not very diagnostic. It's not super duper crazy. So this person's having an infarct in the inferior region of the heart. All right, let's take a look at the next one. Okay, group that 1 and AVL together, 2, 3, and AVF, V1, 2, 3, and 4, and 5 and 6. Those are the ones we're looking at together. Okay, 1 and AVL. If you don't want me to give the answer, just pause for a minute and take a look at it. There is ST elevation there. You can see the isoelectric lines here, and this ST segment is above. It looks kind of like that fireman's hat. It's not a tall fireman's hat, but it's a fireman's hat. Down here as well, ST segment is above. Here's my isoelectric line above. We have a match, 1 in AVL. There is a heart attack happening in the lateral region of the heart. 2, 3 in AVF, there's definitely a change here. But do you see something that we talked about earlier? It looks a little bit like ST depression, but it's not. It has the scooping effect. So what's the scooping called? See the scoop and the scoop and the scoop? This is digitalis. So I know this person probably takes digoxin, and I can ask them outright, do you take digoxin? Or I can look them up in the system, whatever. This is digitalis. It's not necessarily ischemia. It's caused because they take digoxin. So it doesn't mean it's diagnostic. It just means they take digoxin. Okay. So let's look at V1, 2, 3, and 4. V1 looks pretty okay. There's something going on in 2, something in 3, and something in 4. I'm not going to say it at first. You guys see if you can Think about what it is in your head. Give you the answer in a moment. Okay, this is ST elevation. You can see the isoelectric line here. It's way above. Isoelectric line way above. Isoelectric line above. This is ST elevation. 3 of the 4 in the anterior region of the heart are also ST elevation. So this is also having stemming in 2 places for sure, lateral and anterior. And then if we look at V5 and 6, a little elevated here, not so much here. We can't call that diagnostic. So 2 different places we're having a STEMI. I don't like that one. I don't like that one either. I noticed I didn't really do, yeah, these ones, we're going to skip back. All right, that's the last one we're going to do for today. All right, that's it for today. Again, if you didn't understand something, just rewind it and go back and watch it again. If you have questions, you can send me a message, and see you guys in a couple of weeks. All right, have a good one.